Welcome everybody. My name is Russell Crew. I'm the Dean of the College of Health and Medicine here at the Australian National University. It's my great pleasure to welcome you all to this beautiful auditorium in the School of Physics. You hadn't noticed, that's like Burley Griffin out there. You can probably see a little boat sail past. I acknowledge that we're on the traditional lands of the Ngunnawal and the Ngambri people. I pay my respects to their elders past and present. They acknowledge the contribution that they have made to this beautiful landscape and to the lands in which ANU calls home. It's a privilege to be able to live and work here and to learn from them in all matters of body, mind, spirit, culture and country, and importantly how those things fit together in an integrated whole of social and emotional well-being. It's a real pleasure to yet again gather for the Tony Ayers Award celebrations. This is an award that has been made every year since 2014. It hasn't been awarded every year, and one of the recipients of previous years is incognito in the audience, who wasn't awarded his award, but I just want to note Professor Mark Polizotto sitting up there was the recipient last year, and we had an award ceremony, so congratulations, Mark. To date there have been 8 recipients of this award. I think it's a really special award, and it's special because it's more than an award itself, and it's more than a lecture occasion. It's actually an embodiment of a special partnership that the university has with the John James Foundation. And that partnership embraces and celebrates the importance of translational research. We're a discovery science-based university. Our motto is first to understand the nature of things. And we've been very successful as a science-based university. But of course, science only is fully realised and the value of it when it makes a difference to people's lives. And medical science makes a real difference to people's lives through implementation in the clinic, through implementation in public health and in community settings. This prize embodies those who have successfully delivered translational research, have taken work from the lab or theoretical work into a clinic or public environment, and it respects how difficult translational research actually is to do. I'm a clinician. I've been involved in trying to do translational research all my life, to wrestling with recruitment of subjects, ethics committees who are protecting those subjects from harm from people like me, the governance requirements, the funding requirements, the challenges out in the field that are just not there in the lab. And so I think this is a really important celebration of a group of academics who are doing the hard yards for the university, helping us get the science from inside the university out into the public space. The John James Foundation is the perfect partner to celebrate this. Born out of a clinical headspace with a board of directors that is very much representing the clinician expertise of Canberra. They are leaders really in understanding the clinical environment and have been front runners in championing the importance of excellent research and the difference it can make to patients and people's lives. I'm very grateful that Joe Roth, the CEO of the John James Foundation, joins us today. And I now want to take the pleasure of introducing my colleague and friend, Professor Paul Smith, who is the chair of the John James Foundation. And not only that, he's another surgeon. He's a great surgeon though, and a highly decorated surgeon, having received the Excellence Award for research from the Royal Australian College of Surgeons recently, a number of awards from the Australian Orthopaedics Association. He's been president of the Royal Australian College of Surgeons ACT branch, and is an enormously respected figure in both clinical science and in orthopaedic surgery, and in the Canberra community more broadly. Paul, can I introduce you and welcome you to the
Thank you very much, Russ. It's an introduction which I probably don't deserve, but thank you very much indeed. So it's my real pleasure to be here today. Russ has introduced me, and I am the chair of the John James Foundation as one of my little part-time hobbies. The John James Foundation, I'd just like to say a few words about the John James Foundation. Those in the audience may not be aware of the foundation, but the John James Foundation is by far Canberra's largest health and medical related foundation. It's really one of the top 50 in Australia and really has commanding scale. The foundation grew from very small beginnings. Back in the 1970s, anyone who's sort of brought up in Canberra may remember the John James Memorial Hospital. It was set up as the only private hospital in Canberra and grew into a reasonable size, but like most standalone private hospitals, squeeze financially happened, and the business was then sold on, forming the foundation, and subsequently the foundation divested itself of the real estate assets it held in Canberra and became really big, and now has about $160 odd million under investment. It really is quite remarkable. Out of that, the foundation drives a considerable investment revenue, and we are focused on a number of areas. Just to name a couple of those, we've built some outstanding healthcare assets in Canberra. The John James Village is an accommodation facility for people having long-term chemotherapy for cancer. We've built the AEIOU Foundation Early Intervention Centre for Autism, also based over in Garran. And we're now embarking on another infrastructure build with a respite facility for palliative care ACT. So we're having a real impact in the hardcore health facilities sector of our economy. We donate significant amounts of money each year to small grassroots healthcare charities that really need that leg up to be able to undertake what they do. And we partner with other charities such as Hands Across Canberra and the Snow Foundation in doing so. One of our other key endeavours is our partnership with the ANU. We support not only this prize, which I'll just say a few words about in a moment, but we also support a number of scholarships through the ANU Medical School, particularly for Indigenous students. So that's the sort of 25, not quite 25 words or less, description of what the foundation is and what it does in Canberra. In regard to this particular prize, this prize was set up some years ago to recognise the outstanding contribution to the foundation, but also to Canberra and Australia by a chap called Tony Ayers. Tony was one of Australia's most distinguished public servants. Looking back on his career, he was the secretary of not one, not two, not three, but 4 Commonwealth departments. Quite an extraordinary lifetime achievement. He was a man that came from relatively humble beginnings in Adelaide, trained as a teacher, would you believe. Moved to Melbourne and became an educator at Pentridge Jail. One of his great stories was that he met his wife at Pentridge, outside the jail, not inside. He was an absolutely outstanding diplomat, administrator and mentor to many, and he served the John James Hospital Board and then the Foundation Board with great distinction. And when Tony passed away, the Foundation Board decided that we really wanted to set up a prize in perpetuity to recognise his contribution, and hence this prize here. So, that's the background to the prize. But Tony was truly a wonderful person with a great sense of humour. Okay, on to this prize. This prize has grown somewhat and has become a more difficult task for those who have the unenviable responsibility of actually deciding on the recipient. This year, the applications for the Tony Ayers Prize were truly excellent, and the recipient is a very worthy awardee. This year's awardee, pardon me while I read, she holds an Australian Research Council Discovery Early Career Research Award. She is a PhD in clinical psychology and a senior research fellow at the Centre for Mental Health Research here at the AU. Her research direction is to explore the development, evaluation and implementation of technology-based mental health interventions. And this is an extraordinarily topical and important area, and I would be delighted to hear a great deal more. So I'd like you to welcome Dr. Lou Farah, this year's recipient.
Hello. Might move that up a little bit so you can hear me a little bit more clearly. Is that good? Excellent. Thank you so much. I'm absolutely delighted and thrilled and really honoured to receive this award, and particularly because of the nature of this award and how it acknowledges and celebrates translational research, which is really a big driving force for me in my career and motivates me daily in my research endeavours. So I'm very grateful to the John James Foundation for supporting this award and supporting me. Not only also for translational research, but also early mid-career researchers as well. So today I'm going to talk to you a little bit about, I'll sort of wind through my research journey, and I'll talk to you a little bit about the different projects that I've worked on throughout my career, and hopefully share with you some of the meaningful and translational impacts that have happened along the way as I've worked in this area. So, like most, if not all, health and medical researchers, we start with a problem. And this is the problem that has absorbed and fascinated me in my research career throughout, since the beginning. So, 1 in 5 Australians will experience a mental illness. And what we know is that figure hasn't really budged or shifted in a number of years. 2 in 5, so 40% of Australians will experience a mental illness in their lifetime. And so these are significant numbers of Australians that we're talking about. What really drives my research is the problem of unmet need for mental health care in the community. We know in particular that our young people, so those aged 16 to 24 years, are at particular risk for a mental health problem as well. And some of the research that I've worked on has focused on this particular priority population as well. Staggeringly, what we also know is that between 50 and 70% of people who experience a mental health problem don't seek help. They don't seek help for a number of reasons. There are several complex, multifaceted, numerous reasons why people in the community don't seek help for mental health problems. Some of the common barriers are people feel like they should manage it by themselves. They feel like they should be managing on their own and they should be able to solve the problem themselves. Other people face cost or financial barriers. They aren't able to afford mental health care. There's also long waiting times, as we know, and access to mental health care is particularly difficult in areas where there just aren't access to psychologists. We simply don't have enough mental health professionals in particular areas in Australia. So these are important problems that need to be addressed. Another figure or phenomenon that also is staggering to me is that if every person in Australia right now who is experiencing a mental health problem decided that they no longer face barriers, put their hand up and said, yes, I'm ready, I'd like to receive mental health care, we simply don't have anywhere near enough trained professionals to actually meet that demand. There's no way we could ever meet the demand if we think about traditional models of mental health care, which, as you understand, are in the clinic between a psychologist or a mental health professional and a person, that face-to-face, in-person care. So we really need to think about innovative solutions to be able to address this problem and be able to increase the accessibility of mental health care for people in the community who need it. And this is really where digital mental health comes into the picture. So what I'm talking about when I talk about digital mental health is it really encompasses a very wide range of tools, applications, or ways of using technology in mental health care to help get evidence-based support out to people in the community. I'll go through a list of some basic different types of mental health care, digital mental health care, to give you a picture of what I'm talking about when I'm talking about these sorts of things. At a very basic level, technology can be used to screen and monitor mental health symptoms. How many people have gone online, have done a quiz to see whether they're experiencing symptoms of depression or symptoms of anxiety? So these sorts of tools are readily available online and can provide you with some feedback about how you're feeling, how you're travelling. On our mobile phones, we can be monitoring our symptoms and tracking them over time and observing trends in our mood or our anxiety levels throughout the days and weeks. We now have wearable devices that tell us about our sleep, that tell us about our heart rate, our social interactions with other people. And these metrics can be used as proxies for fluctuations in our mental health. They can give us information about our physiology and how it might lead to changes or differences in our thinking and our mental state. Self-help therapeutic tools are really where the majority of my research work has happened. What I'm talking about with self-help therapeutic tools is when you take the type of therapy that you would receive face-to-face with a psychologist and take the sorts of skills and strategies and coping techniques that you would learn in that therapeutic relationship, take it and put it online into a modularised format that somebody can log into a computer, can read information, complete exercises and quizzes, and essentially build that repertoire of coping strategies simply through a computer. No human involvement necessary whatsoever. These sorts of tools can be based on the web, so internet-based. They can also be app-based, so there's many apps that you can download for your phone that will help monitor your mood or will help you to develop more healthy coping strategies or thinking strategies. There's some amazing, really innovative work being done by colleagues, thank you, who are using virtual reality to help treat phobias. So things like spider phobia or phobia of heights, using virtual reality environments to expose people to those particular stimuli to help reduce their anxiety in relation to those. So really interesting and quite novel applications of technology, particularly in mental health care. Interestingly, these sorts of tools can be delivered in many different ways. Sometimes they can be delivered in a non-guided format, and what that means is there's no human involvement whatsoever. There's nobody involved, it's just a computer and you, or you and your phone. Other forms of self-help therapeutic tools can be delivered with guidance. So you might have a professional or a coach or somebody who's helping you use that tool, checking in with you to see how it's going. So there's different sort of models of delivering these sorts of tools. Peer-to-peer interventions, chat rooms, asynchronous bulletin boards and forums are ways for people with lived experience of a mental health problem to connect with one another and to share support and strategies and things that have helped them as well. So these sorts of peer-to-peer interventions are really quite prolific in the lived experience space. Another area that my recent research has focused on is actually looking at the human-to-human delivery of psychotherapy and how that translates to being delivered online, so through technological means. Obviously, the major application of this is through telehealth, which is something that has become enormously important during the pandemic. But psychotherapy can be delivered in numerous ways using technology via email, phone, chat room, and video conferencing are among the more kind of commonly used applications. And finally, there's a way that you can integrate all of these sorts of digital mental health tools into clinical practice at different touch points of the sort of the therapeutic journey. So while people are waiting for a psychologist appointment, they could be using an app or an online program to help monitor their symptoms. Between appointments, they could use digital therapy programs to practice the skills, reinforce the strategies they've learned in that session with their psychologist, or use these tools for relapse prevention. Once they've finished the course of therapy with a psychologist or a mental health professional, they can use these tools afterwards to maintain the gains that they've achieved during that therapeutic process. Digital mental health programs have amazing benefits. They can be anonymous. So this, as you can understand, can circumvent many of the barriers that stop people from accessing face-to-face mental health care. They can use these tools without anybody knowing. They're also accessible. If you have an internet connection, they can be delivered to people in all areas of the world. And if you think about the scalability and the public health impacts of these sorts of tools, the potential is enormous. And finally, they're available 24/7. People experiencing an exacerbation of their mental health symptoms, it's not limited to business hours. It doesn't often occur 9 to 5, 5 days a week when many clinical services are available. And so these sorts of tools are able to be there for people and help people in those times when they may not be able to access other forms of care. They're effective and cost effective. There's now an enormous evidence base to suggest that these programs work. And some of the research that I've done has been to establish that evidence base for these sorts of programs. They're engaging, especially for younger adults. I've put a picture here on the slide, which is amazing. It's a program that's been developed in New Zealand by some colleagues called Sparks. And it's a video game. It's essentially a role-playing video game. It looks and feels just like any other video game, but it teaches cognitive behaviour therapy, which is an evidence-based therapy that you would receive for depression if you went to see a psychologist. So it helps young adults and adolescents change and alter negative thinking patterns and develop different sorts of coping strategies purely through playing a game, which is just such a remarkable application of technology. Digital mental health interventions are also about meeting people where they're at. We're online anyway. 70% of people or more go online for health information. So these are people who are already going onto the internet and using technology for their health. So it's really about meeting them where they're at as well. So I'm going to pause here. Now that I've talked to you a little bit about what I'm talking about when I talk about digital mental health interventions, I'd really like to highlight the important work of Professors Helen Christensen and Kathy Griffiths, who have been my incredible mentors. And these researchers were really the pioneers in Australia in terms of developing the first digital depression programs that are based on cognitive behaviour therapy. They developed the program MoodGym, which was developed here at ANU at the Centre for Mental Health Research, where I currently work. And these researchers were my PhD supervisors, and they really ignited this passion that I have for digital mental health care. They tell an amazing story. In the 25 years ago, they were seeking funding to build MoodGym and to build this digital therapy program. And they were laughed at. It was unheard of at the time that the change that's sacred and occurs between two people in a clinic could ever occur between a person and a computer. It was unheard of. They never imagined that it could happen. And if you think now, it's such a normalised way of life that we engage with these sorts of tools. And so it always just, when I think about how far we've really come in this space, this is such an amazing field to work in because it's accelerated so rapidly and so much change has occurred. So MoodGym, I'll talk a little bit about this program. It was launched in 2001. It has over 1 million registered users. And again, it essentially takes cognitive behaviour therapy and puts it online in a self-guided format, and it can be delivered directly to the community. This is a great slide because that map was actually made many, many years ago, so it's not even current, but it's still quite staggering when you look at it. The places in white on this map are the parts of the world where MoodGym has not been accessed. So users from everywhere on the dark parts of the map have access to MoodGym. So if you're talking about global reach of a digital mental health program, that's incredible, absolutely incredible if you think about the scalability of these sorts of programs. Recently, MoodGym was featured in an NHMRC impact case study, and so if you're interested, I really encourage you to look this up because it's a very beautiful summary of all of the work that's gone into MoodGym. It's been the subject of 40, 50 randomised controlled trials. It's been translated into numerous languages, and there have been many important health outcomes and impacts that have been associated with this program. And so part of my research that I'll talk about has been a small part of this program of research as well. So I'll get into the research and I'll just share with you a study, one of the earliest studies that I worked on actually. And this is a study that I led that was a randomised controlled trial taking MoodGym and implementing it within Lifeline. So Lifeline, as you know, very, very widely accessed community service. Over 1 million Australians call Lifeline each year for support. And what we were interested to understand is can MoodGym, a program like MoodGym, be effective with people who call Lifeline? Not only did we want to look at effectiveness, but we wanted to test different models of delivery of an online program. So we wanted to compare whether it was effective to just give Lifeline callers MoodGym by itself, or whether it was even more effective if we combined that with telephone support. So Lifeline offers telephone support, so we tested that coaching model that I spoke about earlier, self-guided versus the guided model of delivery. So we divided people into 4 groups. One group received MoodGym alone by itself, another group received MoodGym and then weekly telephone support. So someone called them up, checked in with them and said, how are you going with your program? We had a third group that received telephone coaching only, and a fourth group that was a control group. And here's what we found. We found significant reductions in depression, so the program was effective in those who used it, both in the group that just used the program and used the program with the telephone support. Interestingly, we found no significant difference between people who use the program alone and people who use the program with support. So if you think about that in terms of implementation, that has quite significant implications, because what that means is when you involve human support in the delivery of a digital program, the cost rises. Involving humans is costly. And so if you can derive the same benefits from just delivering the program as you do with phone support, the scalability and the cost effectiveness of that improves. In terms of the translational impacts of this piece of research, so after we demonstrated that Moodgin was effective within this Lifeline context, it led to the adoption of Moodgin into Lifeline's referrals database. And so what that meant in practice is that every Lifeline telephone counsellor, if they spoke to somebody on the phone who they imagined would benefit from using a program like Moodgin, they would directly refer them to it. And so it was a way to actually increase the accessibility of that evidence-based program to people who call Lifeline. It also led to enhanced workforce capacity. Based on this research, I was invited to train health service providers, and this was Lifeline staff, but that also sort of branched out as sort of the results of the research were getting more broadly disseminated. I had the opportunity to go and train mental health service providers around Australia in the use of digital programs in their practice. And so this was actually about giving them the skills and providing them with the knowledge and the evidence base for digital mental health programs to try and encourage their use and for them to take it back to their services and to use it within their own practice as well. I'm going to pivot slightly now and sort of move a step further, or a step more towards the present in my research journey, and talk a little bit about the research and development work that we've done to improve the mental health of university students. So I touched on previously that that's really an age, the 16 to 24 age bracket is a period of particular vulnerability for young people. And so we have laid a really comprehensive program of research to try and understand the drivers of poor mental health in university students, and to develop, co-design and implement digital solutions for university students as well. This is an important point to acknowledge that I don't do this work alone, and there's a very, very large team of people that I work with in this particular program of research, two of which are sitting down here, my current mentor and supervisor, Phil Badahan, and my esteemed co-pilot in this research, Dr. Amelia Gallagher as well, and also this amazing team of very skilled people who work in this space with me. So what we did is we developed a digital program called the Uni Virtual Clinic, and what this is designed designed to be a one-stop shop for university students to be able to manage their mental health. So it's a really big digital portal, essentially, that provides information, self-help modules, therapeutic strategies for a range of different issues affecting students. And this was a really large piece of work that we, instead of sitting here as experts and designing it ourselves and then rolling it out, we engaged in this really comprehensive co-design process within the university to build this program. So I won't talk too much about this. This is just the scoping background work we did, a lot of boring studies and things, systematic reviews. We did a number of cross-sectional surveys on campus and a number of sort of stakeholder consultation and focus group type work. But what was more interesting and more fun for us to engage in was the co-design and service model and software development. So I've got some pictures up here. Myself and my team, we really had such a strong presence on campus. We were engaging with students for years around the development of this program, and they really had such a central and important role in what the digital intervention did and provided to them. So it's a nice picture there of sort of the initial wireframe of the intervention and then what the eventual homepage looked like as well. So the UVC, as I mentioned before, really comprehensive intervention. It contained quizzes that provided feedback, tailored psychoeducation, self-help modules to help improve things like physical activity, relaxation, mindfulness, cognitive skills, things like that, and also helping to link students to existing campus services and services outside of the university as well. We run a randomised controlled trial of this intervention at ANU with 200 students, where we gave them the program for 6 weeks and tested whether it worked or not. And we found significant reductions in social anxiety and improvements in academic self-efficacy. I think what really speaks to the power of this intervention are in some quotes, some qualitative feedback that we received from our participants, one of whom said that the UVC helped when making a counselling appointment and waiting for a month just wouldn't have worked. So really talking, harking back to what I was talking about before, the power of digital interventions to hold people while they're waiting for the other forms of care that they signed up for. For another person, the clinic helped them identify what they were going through and then was encouraged them to actually seek help. And so it's a really nice, another application of digital interventions to encourage that formal help seeking from services as well. Here's where the story takes a little bit of a detour. So, as happens in research, we had an amazing amount of research funding to build this portal. We built this big, comprehensive, fancy digital intervention, and our funding stopped. And so we found ourselves in a bit of a predicament. We had created this amazing resource that we knew worked. We no longer had the resourcing to be able to deliver the intervention in its current form. So instead of losing the amazing work that we had done as a team, what we did is we sought additional research funding, but we essentially created a pared down version of the Univirtual Clinic. And we've named this the Univirtual Clinic Lite, or the UVC Lite. So what we've done is we've taken all of that content and really distilled it down into a very brief, low intensity intervention, which if you think about it, for students who are time poor, who may have difficulty engaging in quite complex interventions, we were interested to see what sort of a difference it would make if we made something that was very, very easy to engage with. And so this intervention is very basic. It's essentially 12 3 to 5 minute animated videos. Very, very simple. We developed this on, very, very little resourcing. But it's quite an amazing intervention, and it's quite powerful. And I think what the power of this intervention holds is that it requires such few resources to implement. So if you think about it from that perspective, it's easy for institutions who are resource poor to be able to deliver this sort of intervention to their students. And so we've just finished a randomised controlled trial of this particular intervention with a national sample of students this time. The story is a little bit interesting because what we found, our hypothesis was that an intervention like this would be quite easy for students to engage with. And what we found is that students didn't engage with it very well at all. Very few actually clicked on it and looked at it in the first place, which is such a challenge, right? How do you engage people in an intervention? What we found is that the actual sample that we ended up recruiting for this study actually had quite mild symptoms of depression and anxiety at baseline. So we were thinking that perhaps there was low need among this sample. So the next steps for this research would be to trial this intervention among students who have higher levels of symptoms, just to really test that idea of, do people engage with it better if they actually have a need to use it. So another interesting part of this is that it's made us think more about implementation models. And so thinking, what's the best way to get these videos under the nose of students? We emailed them to students in our trial, and we found that didn't work very well. Students get a large volume of emails, they didn't really click on the links very much, and so perhaps there's a way to embed these videos in curriculum, or to think about delivering them as part of counselling or other sorts of services on campus. And so you can see how starting from one sort of seed of an idea proliferates many different future research questions and directions for us as a team. We nonetheless are going to implement this intervention, so we're actually building a website home for this intervention and these videos, and these are going to be delivered to ANU and to all universities in Australia in 2024. So we're very excited for this resource to be something that's widely available to students as well. The translational impacts of this work on university student mental health. The work that we had done co-designing, building and evaluating the Univirtual Clinic was included as a key recommendation in a report by Origin that was highlighting and calling attention to the problem of mental health in university students. This led to my involvement in the development of the Australian University Mental Health Framework, which has been adopted by several universities in Australia, and as I mentioned before, we'll be implementing this intervention via our website in 2024. The final piece of research I'm going to talk to you about tonight is what I've also been working on very recently, particularly in the context of the COVID-19 pandemic. Where my research journey has kind of headed is that I started in the place of really developing the evidence base. I was really focused on wanting to conduct research to test whether digital interventions work. We want to know whether they work. Then my research sort of moved along the pathway towards developing new tools and then testing them to see if they work. it struck me sort of back in 2018, 2019 that we've now reached a point in the field where we have lots of programs. We know they work, they have a fairly robust evidence base, but the implementation of them in clinical services and in the community is quite poor. Not many people know about them and not many people use them, or as much as we would like, given their evidence base and given how many there are. So I applied for a fellowship to really try and understand and optimise the use of digital mental health programs in clinical practice, and was fortunate to be awarded that in 2019. I was on leave for a year after that, so when I returned back to work, it was right when the first lockdowns of the COVID-19 pandemic were happening. And so my research actually pivoted quite quickly into wanting to understand the very rapid transition that mental health professionals made to telehealth. You can imagine over the course of a weekend, for those working in clinical practice, you'll probably feel this quite keenly. People were working face-to-face on Friday, and then on the Monday, everything was locked down. And then suddenly a whole professional body of people who have, for the most part, never used telehealth before in their practice, were now delivering therapy online for the first time. So I was incredibly interested in documenting that, understanding that, and reporting back on what the findings were of that. And so that led to this study. I gathered together a collaboration of colleagues working in this area in both Australia and New Zealand. We developed a study where we recruited a national sample of over 500 mental health professionals, and we essentially tracked how they went. We asked them questions about how you're using telehealth, how does it feel to you, what are your needs, what do you need to be able to deliver telehealth effectively? What's your propensity to want to use telehealth into the future? All of these important questions. And interestingly, this information was sought by peak bodies such as the Australian Psychological Society to help lobby and advocate for the continued support for telehealth under the MBS. And so, having and collecting this data in real time is really important for decision making as well. Finally, where to next? What question is consuming me next? And I still have some work to do in the space of how clinicians are using digital mental health programs in their practice. But what struck me from the early work that I did in this space is that the clinicians I spoke to in my study were saying things like, I don't use telehealth with these particular clients, or I wouldn't recommend an online program or an app for these particular clients. And that started to puzzle me. I was wondering, why? Why is that? Why would you not think that this particular client group is suitable for digital mental health interventions? And it started triggering some thoughts in my brain about what does this mean for the promise of digital interventions to improve accessibility among vulnerable groups, right? So this problem of digital inequity came into my mind. And this isn't a new phenomenon. This is something that people are grappling with all over the world, researchers and clinicians as well. But I started to think, if the people in the community who are in greatest need of mental health care also face the greatest barriers to engaging with technology, where does that leave us in terms of being able to harness the full potential of digital technology? So I'm working on some research, developing some research projects at the moment, using both linked population data and qualitative approaches to really try and understand and unpack this issue of digital inequity, to try and make sure that the increased digitisation that we're seeing in our health system is not entrenching inequality in access to mental health care further. So that's what's exciting me at the moment and where I'm heading to. That's pretty much me. So it's been such a pleasure to tell you about this work, and those are my contact details if you'd like to ever get in touch as well. So thank you so much.
Lee, that was absolutely fantastic. I was struck by those early figures. It presented 2 out of every 5 16 to 24-year-olds having a mental health illness in a 2-year period. But we're the biggest residential campus in Australia. We've got almost 8,000 students living on campus most of the year. I think over 3,000 of them are going to have a mental health illness. I shudder to think what our counselling service would face with that, and it just underlines the need.
I'm also a psychologist, so I'm actually a clinician and work at the counselling centre. So that's a funny parallel there.
And so, that just underlines the point, doesn't it? That there's no way that could deal with that volume of need. So how does the counselling service talk about these things?
Yeah, well, I think what's certainly happening at the moment is really just thinking about how to use research to understand what the mental health status of our students actually is, and to try and make decisions based on data as well. Previously I think services, particularly on campus, have been a bit of a, you turn up and then you're sort of, you wait and then you're provided with a service without really much sort of pre-screening or intake processes that try and understand fully what students need and then direct them to the right place. Some students obviously are approaching counselling for certain different needs, and it's really about trying to unpack and understand, what are they coming to counselling for, and particularly in the case of some students, can we provide low intensity digital interventions to them? And then perhaps, prioritise students who may be experiencing a more severe, exacerbation of symptoms. So it's about, I guess, smart allocation of those limited resources that the counselling centre has.
Other questions and comments of Lou? A couple of roving microphones. Yeah, one up there. You introduce yourself when you speak of counselling. Oh, it's now.
Hey, very nice talk. My name is Sham. I'm a postdoc in the Neuroscience Division at JCSMR. I have a bit of a side question, I would say. So you were saying that you have some issues getting younger generation to kind of like engage with some of the programs. So maybe I missed it, but like, is it better now? And then could you actually use influencers on like Instagram and things like that to actually use like social media to do good things for once?
Yeah, absolutely. That's a great question. I'm certainly not an expert in the social media space, but I have colleagues who are. Certainly, I have colleagues in particular who are working very much in the body image space, and if anyone's sort of on social media, that can certainly be harnessed to try and change attitudes, I suppose, about how people view their mental health. But it's a great question about can you use social media to actually encourage people to engage. We don't want people to engage with digital interventions. Sorry, I think my microphone's playing up.
Quick question.
Yeah, thanks, Louise. It's just an outstanding oration, and congratulations on your commitment and what you've done. As I promised, I might have a curly question. So, with the inevitable increase in the penetration of the digital world and the increase in computing power and the rise of artificial intelligence, where is this going? Can you see things like maybe even a therapeutic virtual reality avatar arising?
Yeah, the short answer to that question is it already has. Yeah, it's happening, absolutely. The virtual spaces for therapy avatars are chatbots, so people are actually using full artificial intelligence chatbots to receive therapy. So chatbots are getting so clever that they can detect the emotional content of what you're putting in and provide, if you think a lot of the therapeutic change that occurs when you see a psychologist not only comes from the evidence-based strategies they use, but how they make you feel listened to and how they validate your feelings, those sorts of things. Chatbots are getting incredible at being able to reflect back what you're telling it, your feelings, and to help you feel heard, listened to, understood, which is a huge component of therapeutic change. So, not saying that psychologists will be out of a job, but it's an interesting space.
Almost feels like for a surgeon to be out of a job with all this technology coming.
Hi, Dr. Park. Thank you for your talk. That was great. I work at the Clinical Hub for Interventional Research at the John Curtin. My name is Naomi. Thank you for the bit at the end about digital inequity. I think that inequity is always a big thing to consider, especially when implementing new interventions like you are working on. And I was wondering if within that, there's some consideration around particularly people from culturally and linguistically diverse backgrounds. who particularly had a really big, I guess, barrier around accessing mental health resourcing in any form, particularly due to stigma in a lot of those communities. And I was wondering if there's any consideration around potentially how this could actually negatively impact people's help-seeking behavior, especially when it becomes sort of a thing that you can do in secret, if you will, and what the, I guess, stopgap for that would be to ensure that people who need other forms of therapy and intervention are actually able to access them and are supported within their communities to do that.
Yeah, that's a great question. The issue of inequity is a really important one, and it's particularly driven by the fact that many of the digital programs that have been developed are developed in Western countries, have very Western conceptualizations of mental illness and mental health, and many of them also assume a certain level of reading proficiency, psychological mindedness, those sorts of things. And so there's a question there about the appropriateness. It's not simply an issue about language translation. You know, these programs of course can be translated into different languages, but that's not the same. It's also about adapting programs or co-designing and building programs that have deep cultural roots and understanding in different conceptualizations of wellbeing and mental health as well. So that's really important. The point you made about do digital interventions actually stop people from seeking more intensive help if they need it? That's a really interesting question too. I think there's a bit of work to be done still in how to guide people to evidence-based and appropriate digital mental health interventions, ones that are developed by health services, universities that have a solid evidence base, because many, if not all of these interventions will be constantly messaging to users, we think you need further support. So these programs, and certainly the ones that I work with, are not developed to gatekeep, you know, to say, no, stay here and just use our intervention, don't go and talk to your GP. Throughout these programs, any sort of touch point, they will be reminding people that, you know, there are services out there beyond this program. So, but it's a really good point.
And we've got time for one more question.
Hi, my name is Milena and I'm the CEO of the Australian Brain Cancer Foundation here in Canberra. So depression in brain cancer is a really big problem. So what you're doing obviously affects everyone, not just in my industry. But my question's following through with the first question in regards to actually getting that information out to the students. Over COVID, I have 3 kids that go to Canberra Grammar, and what they actually implemented, something very similar, is before every child could actually log onto their portal, they had to view either a video, answer a certain amount of questions before they could proceed, and every time they logged out, there will be a new set of videos. Is that something that you have perhaps looked into in getting it out to everyone, because you've been able to really condense now the information and the videos and get a really good insight of what is going on, whether they like it or not, they have to look at those videos?
Yeah, absolutely. That's a terrific idea, and that's actually one of the ideas that students told us would be acceptable to them as an implementation model. So in addition to those randomised controlled trials I talked about, we did some qualitative interviews with our participants to ask them, you know, if we were to deliver this intervention in a university, how would you like to receive it? What's the best way for us to get it out to students? And that was one of the major or main suggestions that students had, was to embed it in their study portal. So they have to log, you know, when they have to log in to access their course materials, things like that, having it present right there. It's an interesting question about whether you make it mandatory or not. I have lots of thoughts about that, but it's an interesting question. Yeah.
Well, I think perhaps now I could ask Paul back up to the podium here, and can we ask you to present Lou with the prize, the award? Right.